Welcome back to The Power of Peer Support, a podcast about caring for people with substance use disorders. My name is Will Tari.
And I'm Samantha McClay, and this is episode 2. To get the most out of this podcast, please listen to the episodes in order.
So Samantha, in the last episode, we talked about what peers can do that most clinicians struggle with. They can make trusted relationships with patients, grounded in their shared life experience.
Yes, and we talked about how those connections are often formed quickly and become very strong.
And part of the reason those bonds are so strong is unfortunate. Many people with addiction have been mistreated by healthcare workers. For some, it's happened so many times that they lost trust in the system.
Yes, but I suspect many listeners may be thinking that they would never mistreat someone with substance use disorder. Someone else might, but not me. So I have a request. I want you to consider a scenario. You're out in public on a beautiful sunny day, and you see someone who appears to be under the influence. What thought immediately comes to mind? And be honest with yourself. Now, let's take that one step further. What if it's a mom or dad that's out with their small child?
You know, even if your own thoughts are kind, what about clinicians you work with every day? What might they think? Unfortunately, negative attitudes about people with addiction run very deep. We should see addiction as a disease, and instead, many see it as a personal failure. And these attitudes still exist throughout healthcare.
And these attitudes make peer support specialists even more powerful and even more important. So, in this episode, we'll explore stigma, and we'll learn about a program that worked hard to eliminate it. Let's hear again from Sam Landsman. For decades, he's watched how addiction is treated.
Let's say, for example, someone comes in after an accidental overdose on fentanyl, which is pretty common these days, or an infection, come into the emergency room and encounter a lot of stigma. They, are called addicts. They're called drug seeking.
They're called addicts. They're called drug seeking.
Somebody with like an infection in their heart, or somebody who almost just died from an overdose. And then being told, like, why did you come here? We don't want you here. Sometimes, or made to feel that way.
Think about it. If you'd experienced this even once, would you return to a hospital?
There's naturally a bigger wall up for folks who are struggling with substance use issues coming into the hospital. They've felt rejected, or they don't feel deserving of care from us.
They've felt rejected. They've been made to feel like they don't deserve care, and they might stop listening to healthcare providers.
It's impossible to counteract the whole lifetime of stigma. Sometimes you're talking to somebody and they're just not interested in hearing you.
Impossible? Or is it? We'll be right back.
So Samantha, what's been your experience with working with patients in the hospital?
A hospital is a tough place for a person with substance use disorder. It can feel unfamiliar, cold, and maybe even scary. They see authority figures everywhere, and very few friends. They may feel alone, and they might feel like they can't leave. In other words, they might feel just a bit like they're incarcerated.
And those difficult feelings may sit on top of whatever past experiences they've had with healthcare.
Right. And look, I'd say things are getting better, but I'm afraid that stigma is alive and well. For example, not too long ago, I got to know a patient who was in long-term recovery. She had been hospitalized with a severe illness. I have to say, I was uncomfortable observing the clinicians. They seemed to jump to the conclusion that all of her symptoms led back to her substance use. Some even seemed to doubt that she was in recovery.
I don't like the sound of that. What happened next?
Eventually, months later, a doctor chose to look a little deeper and made an accurate diagnosis. The patient was treated and recovered. but not before she had to endure months of needless suffering.
So what do you take away from that story?
As I see it, the clinicians took her case less seriously because of her substance use history. Her pain was minimized. Her experience was somehow less valid.
I'm afraid that's often how stigma shows up. It's not always direct, like when someone is called an addict or some other name.
Right. It can happen in ways that patients are unlikely to notice. For example, sometimes I see dismissive comments in clinical notes. But let's talk about what needs to be done. How can we counter stigma?
Well, peer support specialists can play a big role here. It's hard for people inside the system to counter a history of stigma, but peers aren't seen as insiders.
Right. We work with insiders, but we're seen differently by people struggling with substance use disorder. More like neighbors.
Right. That's why peer support can often engage patients and make them feel more comfortable.
But even if peers do well, the patients still have to interact with other healthcare workers.
Yes, so let's see if we can understand some of the underlying causes of stigma. There are probably many, but one big one stands out, so we may as well start there. Sometimes stigmatizing behaviors, like labeling people as drug-seeking, come from misunderstandings about the medicines that are used to treat addiction.
And honestly, it can be confusing. Medications like Suboxone and methadone are, in fact, opiates. They are cousins of highly addictive drugs like fentanyl, and sometimes they can be obtained on the streets. So, healthcare workers with limited knowledge may think that giving a prescription just feeds addiction. But that's not right.
They do work the same way on the brain, they're longer acting, but we're using it as medicine.
Longer acting, and that's crucial. So instead of getting high and crashing, patients experience a steadier, less intense impact. SAM sees it as appropriate medications because of
Long-standing strong evidence that they reduce cravings, reduce overdoses, reduce the dangerous behaviors associated with, non-prescribed opioid use.
That's important. Non-prescribed opiate use is far more dangerous than prescribed opiate use.
There's the overdose risk, there's the risk of infections in your arms, in your legs, in your heart. We see people have strokes because they have a blood clot that is an infection that goes to their brain. It's really, really scary stuff that makes even young folks who are struggling with addiction, get similar issues that would happen to somebody who's in their 60s or 70s or older. And then trying to find illicit substances, you're putting yourself at risk of getting shot, of getting stabbed, of getting hurt, of getting arrested, having legal consequences to that. And then how do you get the money to pay for it? Whether it's stealing or other things that people wouldn't otherwise want to be doing.
So, simply put, prescribed medications keep people alive. Therefore, when it's medically appropriate, Sam and his team make every effort to get patients started on medications and keep them on them after discharge.
We're looking to make sure that there isn't going to be a gap in them receiving that medication. If it's Suboxone, we try to make sure that they have somebody to prescribe the Suboxone. So just really pragmatic. People can live their lives, especially with Suboxone, which is less regulated than methadone. When you're in a stable dose, you can go to a clinic, you go see a doctor once a month, or even now virtually, you're just taking medicine once a day, like somebody takes their blood pressure medicine. There's thousands and thousands of people who are doing that.
Some patients may eventually choose to come off of the medication.
We often suggest they stay on it for 6 months to a year at least before trying to come off of it.
Coming off means withdrawal, so Sam wants patients to have support.
That's a risky time for relapse, too. So we usually want people to be in a stable place before making that decision. Get stable sobriety, stable support, connected with recovery community, docs, counselors, 12-step program or other peer-based program.
What are your thoughts here, Will?
Sam laid it out quite nicely. Uncontrolled and erratic use of non-prescribed opioids, street drugs, is dangerous and can sometimes be deadly. Steady and controlled use of prescribed opioids is safe for as long as they're needed, and often they're actually life-saving.
Once it's explained, it makes complete sense.
I've seen something more. Cravings can be so strong and intense that people spend huge amounts of their time and energy just seeking drugs, looking for their next fix. In the process, they turn into people they really don't want to be, and people they don't even like. Prescribed medication can reduce craving, and that allows people to put their focus, their time, their mental energy elsewhere. And maybe it gives them an opportunity to rebuild their lives.
That's right. So it's unfortunate that so many people are misinformed about these medications. Even in some recovery communities, being on medications is viewed as non-sobriety.
To make progress, we have to keep educating healthcare teams about these medicines and addressing other sources of stigma as well.
We'll be right back to learn about a team that made such an effort. In this segment, we're going to visit the birthing pavilion at Dartmouth Health and learn about a major effort that improved prenatal care for people with addiction. Reducing stigma became a central part of the effort. Here's Kate Stokes, a nurse leader.
We were really working on trying to get pregnant people who are in active substance use to engage in care. That was sort of the first step.
Getting people to engage in care, that's step one. Kate knows the outcome can be quite poor otherwise.
People would not really get any prenatal care, come and have their baby in active use, lose custody, and never return to care. And there's been high rates of overdose and suicide among this population.
Part of the team's effort was adding peer support specialists, including Megan Adams. Here's Megan sharing a bit about her story.
In my past, I struggled for many, many years. And in 2019, I found out I was pregnant at the very lowest point in my addiction.
Megan soon got help and started turning things around.
I had been trying to do things my way for many, many years, and I failed miserably. I'm like, this time around, I'm going to take suggestions. I'm going to do what's suggested by people that know more than me. And it's worked out really well so far. When I had my son in 2019, the love and support I received from nursing staff was a pivotal turning point for my life.
Megan now works in the birthing pavilion, offering the lessons of her experience to others walking a similar path.
Looking back, maybe it wasn't all for nothing. All the suffering and all of the really difficult times led me to this. Now, to be able to be that person that I needed when I was struggling, this job means everything to me, and it's super important work.
Megan embraces young mothers-to-be with open arms and easy access to care.
If somebody is on the streets and struggling with substance use conditions and they want to get on either buprenorphine or methadone, they are admitted onto the birthing pavilion anywhere from the day they find out they're pregnant until delivery. If they come in their first trimester, we work with them their entire pregnancy, and then we have the ability to work with them 1 year postpartum.
The team ensures that patients have continuous access to help. Here again is Kate.
We also have a helpline, and it is a confidential, anonymous line that is for anybody who's struggling with substance use in pregnancy or postpartum.
Also, those who need it are given a phone.
A lot of people, had no phone prior to getting pregnant. So that is a big part of being able to be in contact with people and us feeling like they're safe. We upload the phone card every month so that they have the ability to call 911 if they need to, or if they're in labor and they need to ask, should I come?
Adding peer support was a strong step. So was 24/7 care. Still, several years ago, Kate and her colleagues felt unsatisfied.
We did a quality improvement project where we looked at the experience for people on the birthing pavilion who have substance use conditions. And what we heard from patients is some people had good experiences and some people didn't. Some people did feel kind of stigmatized for their substance use condition.
Open arms, easy access, good intentions. And yet, some patients reported they felt mistreated. Kate and her colleagues looked for an underlying cause.
And what we found was that a lot of the nursing staff had never really had specialized training in substance use conditions.
A lot of nurses, some with decades of experience, had never received any training in how to treat substance use. No surprise then that legacy beliefs persisted.
There used to be this weird thing in healthcare when I started on the birthing pavilion 13 years ago where people talked about tough love.
Tough love, meaning
The way to help somebody who was struggling with substance use disorder was to shame them essentially or tell them they needed to stop.
today we know tough love is ineffective. Kate brings new hires up to speed.
I can sometimes tell they have sort of an old school view of substance use. I will provide a lot of on the job immediate training of no, this is how we frame this.
She also added more formal training.
So we started doing trainings about substance use. Nothing enormous, but enough information that helped really frame substance use conditions as a medical condition, not a moral failing, not a choice. This is an illness like other chronic illnesses that has periods of time where it goes better and periods of time where people struggle.
Looking back, Kate believes educating the staff and pushing back against old school attitudes were critical steps.
Definitely have faith in the impact that the educational sessions will have for the staff. Doing that foundational work, I think, is so key.
But it takes more than training.
People are much more likely to be stigmatizing towards a person in front of them if they don't know how to help them.
Health providers are much more likely to stigmatize when they feel helpless and when they feel fearful about the baby's health. That's more likely when they lack skills and knowledge, and thus feel they have few options. They feel
Our only option is to call child protection because we don't know what else to do to help keep this mom and baby safe.
Megan has learned how to connect with nurses who feel this way.
Just telling them, I know how hard it is to care for a mom and a baby, that you're scared the mom might not survive when she leaves here. That's really hard on nursing staff, and to name that and make them feel like they're not wrong for being concerned.
But there's something even more important than validating the nurses' feelings: giving them alternatives to calling child protection.
We have a lot more options now, and they feel, kind of like an ownership over these people's lives changing, and mom being successful and baby being safe and loved on. People want to feel like they're helping.
Then you help create an environment where people feel empowered when they're working with this population. I know what I can do. I can really be helpful. And this person in front of me needs my compassion and my support, not pointing out failures.
One part of the training proved very important.
We also have done education about medications for opiate use disorder, about methadone and how it works, and about buprenorphine and how it works.
What did you take away from that segment, Will?
In brief, I'd say that stigma's a really big problem, but it's one that we can overcome. Adding peer support is powerful, but basic training around addiction and recovery also matters.
And some of that training is about medications like Suboxone and methadone.
And a lot of it boils down to seeing addiction for what it is. Addiction is not a choice. And this is a bit confusing to some people, because sure, taking a drink or a hit is a choice, at least in a narrow and immediate sense. But addiction is not a choice.
Will, just to be clear, nobody ever chooses to be an addict.
That's right. No one would ever sign up for this. Addiction is not a choice. It's not a personal failure. It's not the result of personal weakness. It's a disease and a condition of the brain that makes it nearly impossible to fight cravings. And the response to any disease should never be tough love. It should be compassionate care.
Absolutely. You know, Will, I've seen many people with addiction struggle to be compassionate even with themselves.
Yes, so tough love? That only makes things worse.
I want to highlight one more comment Kate made, that healthcare workers are more likely to stigmatize when they feel helpless.
It's actually human nature. Healthcare professionals want to help. So if they lack skills and knowledge, they may feel like they have nothing to offer, and that feels very unpleasant. Their natural inclination is to shift their attention to another patient, someone that they feel they really can help. And that instinct to shift attention to someone else can come across as dismissive or as stigmatizing.
So, part of what made this team better was expanding the ways to help, so everybody on the team felt like they had positive steps to take.
That's right, and peer support was a big part of that.
In our next episode, we'll dive deep into what peer support specialists do at work, hour to hour, day to day.
I'm looking forward to that. Thanks, Samantha.
This podcast has been brought to you by the Department of Psychiatry at Dartmouth Health, hosted by Will Torrey and Samantha McClay. Special thanks to all of our guests. Editing by Kay Jankowski, Aaron Barnett, Greg Norman, and Mike Lawless. Script development, audio production, and music composition by Chris Trimble and Treehouse Audio Productions. Please see the show notes for more information.